Hello everyone, this is Shad Reyes. This is Hard Trending. TCT has been full of late-breaking trials, as you know, and with your busy schedule, I'm trying to summarize as much as I can for all the trials that are presented, with some discussion related if this is related to your practice and applicable. With that, we have a lot to go through today. I know last video was 20 minutes. I'll try to cut it short to 15 or even less this time. So let's dive in really quickly. All right, there's a few studies, as I mentioned in the announcement on Twitter, related to the trial. So the first one will be as follows. So before we go, I just want to point out that all these trials and studies are on TCT MD, and thanks so much for all the teams working hard. I would like to give a shout out for Stephanie Gooch, who's really been pioneer in putting all this together, and also for Shelley Wood and her team for posting it. All these can be found, the slides can be found as a PDF for non-platinum members, but platinum members can get the PowerPoint presentation as well. So let's start with the structural heart trials, starting with the Scope 2. Scope 2 is a comparison of self-expanding bioprosthetic for transcatheter or TAVR in patients with symptomatic severe AS. So basically what they did, they compared the AccuRet Neo, which is a self-expanding valve done by Boston Scientific, to the core valve, which is a Medtronic valve. As you see, there's a 300 or shy from 400 patients were randomized to receive the therapy. There was no difference in terms of comorbidities, STS score. They were in the intermediate risk population, and again, no difference in the presentations. The primary endpoint is for non-inferiority. So basically, they are looking to see if the AccuRet Neo were non-inferior to the Medtronic core valve, and the primary endpoint was death or stroke at 1 year, as well as per protocol and intention to treat. But the problem, unfortunately, they did not meet the non-inferiority. As you see here on both graphs, the AccuRet Neo did not meet non-inferiority for the valve, and the author concluded that at 1 year, did not complete an non-inferiority in terms of efficacy. However, there was a little bit difference. There was no difference in terms of the pacemaker as well as perivalvular regurgitation. Moving along in the structural space, REFLECTII, another trial that we'll go over it, but again did not meet the endpoint as well. The background, as you know, there is a risk associated with stroke ranging from 2 to 6%. So the TriGuard, which is a new full shelter, full tent that covers the whole innominate, carotid, and left subclavian, were randomized. This is the graph that goes. This system goes through 8 French over the wire delivery system, but I think it goes through. It requires 9 French sheath. As you see, it captured the debris, and it also, when it collapses, bring all this debris outside the system. Again, they randomized these patients in phase 1 and phase 2. Phase 2 is the TriGuard III, which is the third version of the drug or the device. Again, stroke timing in hospital versus 30 days. As you see, there's a non-significant difference between the with and without protection. Stroke, disabling stroke, or non-disabling stroke. However, the total volume of ischemia or number of MRI non-clinical significant stroke was a little bit higher in the not protected population. And the author concluded that, again, the trial met the primary safety endpoint, was safe. However, compared to the control at 30 days, there was more vascular complication in the TriGuard due to primarily to TAVR related vascular complication. Again, we need to get more granular into the outcome and why these patients had more vascular complication. Again, this system require 8 French extra access for deployment. And the study did not demonstrate any superiority of TriGuard compared to the pooled control for primary hierarchical efficacy endpoint. And as I mentioned earlier, the MRI analysis showed reduced large ischemia lesions. Again, another study that did not add much to our daily practice, but maybe there's a space or there's an indication for this device in certain patients, especially who has higher stroke rate. Well, this is a subject to discussion and more trials down the line. Moving along to the MITHRAS trial. MITHRAS is very interesting. This is for a patient who had mitral clip or any left system or TMVR requiring transeptal access. As you know, there's some patient left with the iatrogenic septal defect. Therefore, and as I mentioned in the summary here, 24 to 50% left with that. However, the author suggested maybe that can add risk to the patient, especially heart failure with LV, loading more on the RV, and more importantly, decreasing the preload for the LV, as showing in the pressure volume loops. So what they designed patients who are randomized, 40 patients in the closure and 30% in the conservative management. Again, primary endpoint, no difference. P-value 0.7 and 0.9 for conservative. So there's no difference at 6-minute walk distance at 5 months. Again, as I mentioned, the endpoint here is purely heart failure and measured by 6-minute walk. Similarly, mortality and rehab at 1 year, Kaplan-Meier, no difference, and the lines match each other throughout the process. Again, there is no, that's actually reassuring that whatever we do for the mitral clip or and we leave an iatrogenic defect, there is no need to close it. However, also there is some room for a patient who has advanced heart failure, or maybe there is an evidence for shunt run suggesting more RV loading issues. Therefore, maybe there's a room for this device for the closure. Moving along to the coronary late-breaking trials, and here I would like to highlight, this is, I think, was a busy day, but I think this is one of the most highlight of the TCT-MD and TCT 2020. Shockwave lithotripsy for calcified coronary, presented by Dean Kyriakis from Christ Hospital. Again, just to tell you, to allude to a few things. As we know, we are doing more IVUS. We'll come across the ultimate trial now for pre and post, but as we do imaging, we are more optimizing therapy, and we are more giving appropriate therapy for these patients, even if it requires a atherectomy or shockwave, whatever. But here we'd like to focus on when you see angiographic evidence of calcification, the chances that this calcium sitting in the media is pretty high. Also, IVUS or OCT will confirm that for you. So again, this is a single arm study where they involve patients. They were supposed to be 400. They ended up with 384. 30 days follow up, 1 year and 2 years. So what they presented now, it's 30 days. And this is a majority of this population was in the US. This is to gain approval for FDA. Major endpoint. Primary endpoint, the obvious one, the MACE, which is cardiac death, MI, target visitor vascularization, effectiveness, successful stent delivery and deployment. Secondary is related to the crossing and angiographic issues. Inclusion, I would like to bring your attention to one important thing. Look at the last point here. Lesion site severe calcification, angiographic radiopacities prior to contrast involving both sides of arterial wall with total calcium length more than or equal to 50 millimeter, or presence more than 270 degrees of calcium. We see this a lot actually in practice, and severely surgical turn down, patient with advanced kidney disease, dialysis. We see this almost on daily basis. So this is where IVUS and imaging is critical to evaluate these lesions and also treat them properly. Randomize these patients for intention to treat, again, at 30 days. Demographics, the usual culprits, hypertensive, diabetics, the people who had MI before, CABG are less, and again, these patients never had stent in the treated segments. Majority of the vessels were disease was an LAD as usual, and calcium length almost 50 millimeter. And severe calcification is 100% in all population. Otherwise, they will not be included in this trial. And the number of catheter was 1.2, which is maybe one didn't work, but at least the majority of the patients received one catheter only, and they receive a total of 68 pulses on average, plus minus 31. So these are when you deliver therapy, you give 20 pulses each therapy or 30 pulses. Unfortunately, I don't have my hands on it now, but hopefully we'll have it in the market soon. But we have experience with it, especially in the peripheral, where it delivers 30 pulses per treatment. Angiographic outcome, as you see here, look at that. I mean, final instant stenosis is significant reduction in the diameter. More importantly is angiographic complication. Zero perforation, zero closure or abrupt closure, a slow flow, and no reflow. Again, we have to pay attention. This is a balloon-mounted device. They have emitters that emit energy throughout the therapy. So it's a balloon. So as long as your delivery is appropriate and you're delivering in the right segment and with no hyperinflation, you are in safe area here. And again, in terms of safety, it meets the safety endpoint as well. In hospital and 30 days MACE are also negligible, nothing significant between the two groups. And in conclusion, again, this is an extra and more tools you can have on your cath lab shelf that are for patients with severe calcification, especially media. And as I mentioned, and I heard that before, if you see calcification on the wall of the coronaries before even injecting contrast, this is where you have to think about atherectomy. This is where you have to think about the IVL and appropriate therapy for proper apposition of stenting and a proper deployment of these stents on the treated lesions. We're at 11 minutes now. We are in a race here. Let's move on. XIENCE 1928. This is presented by Dr. Roxana Moran, and Marco was also the co-investigator. This is looking at the short DAPT for XIENCE. As you know, DAPT is essential in preventing ischemia, but also high bleeding risk population is 40% of the patient we presented to the cath lab. Therefore, they're high risk for bleeding. So the shorter DAPT, the better. Aspirin, Plavix, aspirin, clopidogrel, aspirin, ticagrelor, aspirin, prasugrel. So the hypothesis here, can we shorten the DAPT therapy to 1 month and then continuing with aspirin, or 3 months, 90 days, and then continuing with aspirin alone to decrease the dual antiplatelet therapy? And to evaluate the safety, number one, no thrombosis issues, and efficacy, and also no bleeding issue, or the other way around. Sorry for that. So XIENCE for DAPT program, again, as I mentioned, 1 month and 3 months arm. Patient receive on the index PCI and then receive DAPT for a month and then stopped and then continue with aspirin alone, and then on the second arm for 3 months and then stopped and moved on with aspirin alone. A lot of antiplatelet therapy presented at TCT this year. All death and RMI safety. Is it safe? And there is no, yes, at 3 and 12 months follow-up, there is no difference as you see here. Certified by the risk, there is no difference. There's no, meaning there's no thrombosis. Similarly, all death or MI, no event, and no, it's slightly different at 1 month compared to the controlled propensity match cohort. At 90 days, same thing, safe and less bleeding for sure. And the conclusion was, it's phenomenal. 1 or 3 months of DAPT after compared to 12 months is non-inferior to ischemic outcome and similar rate of clinically related BARC 2 and 5 bleeding with a significant reduction in major bleeding, 3 to 5 BARC classification. So this is all the great news for high bleeders. This is another thing you can consider for patients who are high risk for bleeding, going for surgery or any other intervention. Moving along with DEFINE-PCI, we're back to physiology here. Manish Patel and Patel Jumaya, the investigator, and Dr. Greg Stone, phenomenal study. This is very important, and I cannot highlight here. I would like to highlight here the importance of having a very good pressure wire. You have to have a good pressure, reliable wire in the cath lab where you can do your measuring before and then after when you are done with optimization. So this is an optimization study. DEFINE-PCI, as you know, these are the patient who has physiologic IFR that is significant, less than 0.9, sent to the cath lab, done the PCI, and ended with a stent. However, in that study, they showed 24% post-cath, PCI had an IFR of less than 0.9, means still significant, still flow limiting. And out of those, 81 has a focal and 18% has diffuse. Forgetting the fact that a majority were focal, means there is an area for improvement. Either we have to post-dilate the stent or we have to add more stent to extend to the prior stent to cover that area. So DEFINE is a 1-year follow-up to look at the changes in the angina symptoms as well as hard outcome, cardiac death, MI, target visual revascularization. Again, looking at I just want to bring it to your attention why they picked 0.95 as a cutoff, because this is the best area under the curve or ROC curve that meet 74% accuracy. So that's why in this study, they looked into all patients who had less than 0.95 post PCI and if that has any negative outcome on these patients. Indeed, patients who had post PCI IFR less than 0.95 indeed had worse outcome compared to patient who had IFR more than 0.95. If you see on the cardiac death, spontaneous MI, or clinically driven TVR were higher in patient who has at IFR less than 0.95. Similarly, cardiac death or spontaneous MI also was higher in those patients, meaning we have to optimize these patients. And the hazard ratio is higher in patient who has IFR 0.995. Diabetes age didn't differ much, but diabetic did, and also acute coronary syndrome. But 3.3 hazard ratio for IFR. So we are letting these patients getting out of the table, going home with this significant IFR or non-significant less than 0.95, between the range of 9.9 to 9.5, but still they have worse outcome. So this is where we have to optimize therapy, and this is where the trialists suggested that we have to, they suggested to do an ongoing trial which is called DEFINE-GPS, looking at this cohort of patients and how we can treat them and what will be their outcome. Lastly, is again imaging and physiology, but this time is imaging. We cannot emphasize. We change a lot of practice lately in our cath lab based on this trial. Now we are presenting a 3-year follow-up. This time, it's published at JACC Intervention Journal. Again, as we all know, the ultimate trial showed a fewer 1-year TVF after IVUS guided drug-eluting stenting, and compared to angiographic alone. So again, they are looking at 3 years outcome. Would this differ? Indeed, this is the randomization we're all familiar with. At 1 year follow-up, the TVR rate or the hard outcome was 2.9 in the IVUS guided compared to 6.1 in the ING guided. So did they maintain this ratio or this difference in outcome in the 3 years cutoff? Yes, indeed. 6.6 over IVUS guided and 10.7 an angiographic guided, meaning we have to continue to do IVUS pre and post. And would like to bring your attention to one thing here, which is the cutoff here at 12 months. See, there's a big jump for both of them, for both the IVUS guided and non-IVUS guided. I don't understand why that jump, and I think during the later breaking trial presentation, a few of the moderator asked if they can do landmark analyses starting with this year and what driving that jump and the outcome. So, and again, the author concluded that this is IVUS should be done routinely, and IVF for patient receiving stenting pre and post for optimization. And we mentioned it earlier in the DEFINE-IFR. We mentioned it in the Shockwave trial, which is the disrupt CAD III. The more you see, the better you optimize, the better option you give to the patient, and the more opposition of the stent on a healthy segment. With that, I would like to thank you all for following and also for watching. This is trying to summarize as much as I can in a short period. Now we are at close to 20 minutes, but again, a lot to cover. There is more summary coming up soon again for day 3, more structural trials, and then TCT, as you know, is going through Sunday. And all these trials and presentation and live cases are on demand, so you can access them at any time. And again, I would like to put the plug for the TCT MD. All these resources are available at your fingertip, and you can find them there. With that, I would like to thank you for your attention. Hopefully, we'll see you tomorrow for more summaries. This is Shadi Reyes, and this is Hard Trending.